Thank you very much, Mr. Chairperson. I'll go back to my first slide. Can I move to the first slide, please? Very good. Thank you very much, Mr. Chairperson, and I'd like to thank you, the organizers, for kindly inviting me. I've never been to Halong before. It's a beautiful city, and I really enjoyed seeing what I saw from the balcony window. I'd like to congratulate the organizers for a fantastic conference, and I hope to contribute to this conference this morning. As we know, stroke is a major cause of death and disability globally. No part of the world is untouched by stroke. As you can see from this presentation, from this slide, from the Global Burden of Disease study, a lot of the burden actually is in Asia, whether it's in it's in China, Mongolia, Southeast Asia. Many of these parts of the world are very much affected by stroke. Whether a person lives or dies, how much disability they have, mild or severe, depends on a number of factors. The risk factors of their stroke and whether it's well controlled or even detected, how good the stroke care is, thrombolysis, thrombectomy, and that sort of treatments. Is there an organized stroke unit to look after the patient? Is there good rehab and long-term rehab? Does the patient take their medicine? And of course, that's natural history. All these factors will affect how the person gets a stroke or recovers from stroke. When there's lack of blood flow, the cells are unable to produce enough ATP. Adenosine triphosphate is the important energy molecule that drives cell function. So when there's ischemia, this energy actually starts failing, and the cells cannot maintain adequately their resting membrane potentials or respond to signals coming in. So when this happens, many things that are not good to the cells will occur. Unfortunately, some releases occur of transmitters, some receptors get activated, and various cell processes occur that lead to further and further unfriendly effects that finally lead to cell death. So these occur together. There are many more processes, but the main problem is failure of blood flow, not enough ATP, and the cells dying. But there is also more. In the very acute phase, when the cells are not able to have enough ATP, they can't break down all the bad products. There's a lot of excitotoxic effects in the cells. There's a lot of depolarization around the infarct region, and many cells die within a few minutes. As the hours pass, there's inflammation. These white cells start coming in to try to clear up the mess that is there. They release interleukins and other chemicals that, in fact, sadly, further worsen the damage. And some cells shut down, apoptosis, and they just stop working completely. So all these things happen at various time points during the process of cell ischemia. So any therapies we give are trying to overcome these effects. But cells do recover. At the very core, some cells will die. We cannot save them. But surrounding is a penumbra which we can save. As time passes, the core becomes bigger and bigger, and the penumbra gives way and dies. But still, cells can recover, especially if we can return flow and try to block these negative effects of ischemia. You'll see here over time, as the days pass, months pass, years pass, certain things happen in the acute phase and some things occur later. In the very acute phase, there's removal, recovery of the acute processes. All the toxins, the free radicals, the superoxides are being removed. There's return of flow. The penumbra, which is next to the core, is beginning to recover because there is, like I said, return of flow and removal of bad chemicals. The cells can reorganize on that part of the stroke and also contralaterally. There is reorganization, which is enhanced by rehabilitation in these persons of various pathways, including new synapses may be reopened. There's sprouting of collaterals among the axons that reconnect among the various cells, neuroplasticity, and genesis. There's even so much more than this. But you can see so much is happening that helps recovery to occur. Some would say we can split early and late. Actually, there are a bit of overlap, but generally in the early phase, in the hours, minutes, days, there's a refusion of the penumbra, there's less edema, the toxic chemicals get reabsorbed or cleared, and the damaged neurons, in the penumbra especially, are beginning to recover. In the later phase, there's what they call neuroplasticity, there's sprouting, there's new pathways that are being uncovered, dysgenesis sets are getting reversed, and there's unfortunately some supersensitivity leading to some spasticity. But all these occur together. You're all clinicians, you're doctors, nurses, therapists. You ask yourself, is my patient going to get better? How can I predict recovery? Among the strongest factors in recovery are age, the type of stroke they have, and how severe it was at the start. In this nice cohort study, they found that those who are older have a worse stroke, those who are younger. Those who are older recover more slowly and less completely compared to the young. Similarly, those who have a total anterior infarction called a TACI have the worst stroke, recover very slowly and sadly not very much. The lacuna strokes, the pure motor stroke, the pure sensory stroke, they have a milder stroke, they recover faster and overall do better. Hemorrhage is worse at the start but recovers reasonably too. Again, by stroke severity, those who have a severe stroke NHSS have the worst recovery, those who have mild do well, but all takes time. It slows on over time, and for some, there's no full recovery. So what can we do as clinicians when we see our patient? I've already mentioned earlier all these various stages of acute stroke. We now have good treatments, and today you'll hear lectures from our other speakers discussing thrombolysis, how can be faster, thrombectomy to return flow to the penumbra. You also will hear about neuroprotectants and neurorepair, and importantly, drugs that help with post-stroke rehabilitation recovery. We had the privilege to do a meta-analysis with some stroke experts from the region. You may know some of them here. In this publication that just came out earlier this year, we tried to look for studies that were used as therapies to improve post-stroke outcome. We used a systematic search and review process to find such therapies among adult patients with stroke. We looked at drugs that were already registered in the various countries or could be used, and we looked at what was happening in terms of outcome neurologically and functionally. Look at cell design, the study design, the cell size, when published, and then use the American Stroke Association grading for level of evidence. We found from our search almost 8,000 papers, almost 700 full papers were reviewed. We found suitable publications, 58 of them, that went across 25 pharmacological classes in ischemic stroke, in hemorrhagic stroke, in both, in SAH. There were many meta-analysis and reviews we prefer. We couldn't find meta-analysis or survey reviews. We used RCTs, randomized blinded controlled trials, but we couldn't find in some, and we'd use cohort studies. So very clear of which has the best evidence as we go down the line. Of all the drugs we found, only nimodipine was clear level of evidence A in reducing stroke outcome after the SAH, and therefore all patients with SAH will now receive at least oral nimodipine to reduce the effects of ischemia, especially occurring in the presence of vasospasm. There were other studies that we also done, and there were some that had a level of evidence B on randomized controlled trials that could give evidence of benefit. But while only nimodipine was effective, there are some therapies that can work. I'll discuss one of them today, which we were involved in. But no matter what we do, it's important to look at the overall process of recovery. That neuroprotectants, all the acute drugs, we were involved in many of the trials by various sponsors, by various agents. None of those acute neuroprotectants work. Maybe we were too simplistic, but they didn't work. Maybe we need to think again about multimodal therapy, where multiple things need to come to overcome all the processes to help acute phase and the chronic phase, and therefore improve post-stroke recovery. I'd like to share the trials we did on NeuroAid because we have some experience with it. I'd like to share our experience with the acute trials, and some sub-analysis helps us understand who we can help and who we probably can't. MLC 601 was the first drug that we used. It contains 5 non-herbal and 9 herbal components, and 901 contains only the herbal components mentioned here in the various doses and the various forms. Some were roots, some were rhizomes, some were flowers, and this was used in the clinical trials. We had confidence from preclinical studies and animal studies that it could be done because there was some therapeutic effect on the animal models. We were very happy from those early studies. There was no long-term toxic effects. There was no concern about high-dose toxicity among rodents, and therefore it could be done safely in humans with a chance for recovery. When after stroke occurs, we're trying very hard to do neuroprotection. And the earlier trials of neuroprotection did not work because they could not overcome all these bad things like toxicity, inflammation. They just did not work. But from the animal experiments, there was some evidence, which we were very happy to see, that it could reduce infarct size, could make the cells more viable, they can live longer, it could protect against glutamate-induced toxicity, and could reduce all the stress from oxidation or lack of oxidation. Other animal experiments that were done with NeuroAid also showed that they enhanced neural repair by increasing BDNF, an important component of neural repair. At the same time, like I mentioned earlier, for recovery, it helps new cells to form, new neurites to grow out from the cells, and increasing linking, synaptogenesis. So all this was from the animal experiments. Does this translate to clinical benefit? So here the trials, the CHIMES trial was done for the hypothesis whether MLC 601 given for the first 3 months would improve recovery and up to 2 years. In this randomized controlled trial, that was sent in Singapore, Philippines, Thailand, Sri Lanka, Hong Kong, and Malaysia with more than 1,000 subjects. And we then planned in the CHIMES-E to follow up for the next 21 months. We published this paper in Cerebrovascular Diseases, and you may refer to this if you wish. And I must thank all the various people who took part in the study, here all the many investigators who were involved in the trial, and we thank them repeatedly. So in this trial, CHIMES and CHIMES-E, those 18 years old or above had acute ischemic stroke, were moderately severe, had brain imaging, would then receive NeuroAid or placebo for 3 months in a randomized, controlled, double-blind fashion. In the initial study, outcome at 3 months was at MRS, which is Rankin score, NHSS, and Barthel index, as well as some cognition. For CHIMES-E, they were also followed up for the next 18 months, 6, 12, 18, 24, to see their outcome in MRS, Barthel, and safety. During this entire 2 years of treatment, they received their usual stroke care, their usual rehab by their doctors. Importantly, blinding was maintained to the doctor as well as the patient and the family. So blinding was maintained throughout the study to reduce any risk of bias. What did we find in our study? That overall, at 12-24 months, there was no difference in MRS shift. But if we use dichotomy MRS 0 to 1 versus more than 1, there was a clear benefit in NeuroAid as seen at 6 months, 12 and 18, before becoming just non-significant at 24 months. So there was a delayed onset of a significant benefit that became less over time of the first 3 months. We asked ourselves, who else can benefit? Are there subgroups that can benefit from NeuroAid? We therefore performed this sub-analysis among those who received rehabilitation. So among the CHIMES-E subjects, those who had rehab or no rehab, among the rehab group, we looked at those MLC versus placebo and again versus placebo. What did we find? Consistently, whether you use dichotomy, MRS, or Barthel index dichotomy, it was clear that there was a benefit of combining neuroaid with rehab, and that effect was seen very early, that's sustained over time. They use the dichotomy. So rehab combined with neuroaid does confer a significant benefit. The other outcome measures were consistent with the primary finding. And this, even though we adjusted for older age, for female sex, for pre-stroke severity, stroke severity, the benefit was seen across after these adjustments. We then asked about serious adverse events, death, hospitalization, needing urgent surgery, having a pregnancy and abnormal babies. All this is looked at in a study of the serious adverse events in chimes. Was there an effect on serious adverse events? Well, there was no increase in adverse events, but in SAEs, there was interestingly a benefit. If you look across the study population, no SAEs, 1 or 2 or more, there was a benefit significantly statistically, and importantly, among those who received 2 or more SAEs, the neuroaid reduced the number of percent of patients who had 2 or more SAEs during the time of the 3-month study. So neuroaid also can reduce the number of serious adverse events in this sub-analysis. It also recovered more quickly. That those neuroaid, which in this group, had a faster recovery than those on placebo, and therefore reduced the time of hospitalization significantly in these patients. Did they recover more quickly? This is a new approach. More and more studies are looking at time to recovery. Do they recover faster if they receive a new therapy? It's being done in cancer, being done in dementia, and therefore you'll see this in the new trials in stroke about whether there's benefit in early recovery. So in our sub-analysis, we found that this is the people of outcome 0 to 1 among neuroaid, and this is placebo. So the end of 2 years, about 45% or so had recovered in the placebo group. The neuroaid, about 50%. So this neuroaid group achieved it very much earlier. So you can see that clearly if I draw a line from here to here, there's a clear benefit. Neuroaid reached the same outcome within a period of 6 months. So much faster than the placebo group. So therefore they recover more quickly. And that was very encouraging. So overall, there was a benefit. So while the placebo group of 38% recovered fully, more recovered in the 601 group at an earlier time point. And the statistics is here, showing the benefit at an earlier time point. So we were very cheered by seeing benefit across various outcome measures, from recovery by dichotomy, benefit with rehab, fewer SAEs, and quicker recovery in our patients. So we felt that this was supporting the earlier animal studies of improved recovery after stroke. No study can be done alone. All good research now requires good collaboration. In Vietnam, we have a wonderful organization. I see many stroke experts in the audience. I see Dr. Tang, who is here with me, and I've worked very hard with him over the years, and many other doctors here. It's collaboration. By working together, you can achieve so much. I've read many of the wonderful papers that come out of Vietnam. I'm the editor and editor of some of the journals, and I'm happy to have them published in our journals. Please keep up the good work, and please collaborate. So for chimes, we must thank our collaborators from Philippines, Thailand, Sri Lanka, Hong Kong, Malaysia, who all work together for this study. So Mr. Chairman, if I can make some concluding remarks, we all know that stroke is a challenge, and recovery is a challenge for the patient as well as the family and all people looking after stroke patients. And those elderly, those who have major stroke, are the ones that have the least recovery. Fortunately, we have some good interventions: IV TPA, thrombectomy, decompression surgery, stroke unit care, all can make a difference, but we can do more. We have evidence that neuroaid does improve recovery, better rehab, and has a fewer SAEs and shortest recovery time. And we are now doing another trial called the Maestoso trial. In Maestoso, we're doing further studies on neuroaid to see if we can do even further benefit for our patients. Before I end, may I invite all of you to come to Adelaide for the Asia Pacific Stroke Conference in September. It is just for 2 months from now. Please register, please come, please present your work and make many, many friends. With that, I thank you, Mr. Chairman, ladies and gentlemen. Thank you very, very much.